Now, let's talk to a little bit, though, and see if there's any reporter questions out there this morning.
Hey, good morning. Cody Holyoke with Channel 9.
Cody, welcome back.
Cody.
Thank you, sir. A number of outlets are reporting a new study pointing to 7 variants in the U.S. I know that I looked into it. I know this hasn't been peer-reviewed yet, but it's making the rounds online, so I figured I'd ask. What should people take away from this? I know that they believe it started, some of these were detected in Louisiana. I just know that it's making headlines, so I figured I'd ask.
You bet. Great question. Well, what we know, Hawk, is that coronavirus shifts all the time. If you are a Trekkie, you'll know it's a shapeshifter, Cody. But the reality is that coronavirus shifts all the time, and all its different forms. So the common cold coronavirus shifts its form all the time. And so it's not a surprise that the spike protein coronavirus is starting to shift its form, because when it gets into patients and it goes into your body, it mutates pretty rapidly from one to another. So there's probably more than 7 variants out there. The question isn't, are there variants? How well do they respond? Do they have that spike protein that the vaccine is geared to, Hawk?
Yeah, and we talked about this as well. That's why the CDC has kind of gone away, and people are going away from saying the UK variant and the South Africa variant, because we don't know where those variants popped up. Where they started, that's where they were discovered, that's where they were found. But the same thing for the U.S. And we even said, well, we know that there's those 3 variants that get a lot of the press, the Brazil, the UK, the South African, what have you. But are there only 3 variants that are circulating in the world like that? No, there probably are others. We just haven't been able to identify. Now, this study, this preprint, does show identification of 7 different variants, but that have one key critical mutation or amino acid substitution in that spike area. So it is not unheard of. We anticipated this. But as we are rolling out more genomic sequencing around the nation, hopefully we will be able to pick those other variants up if they do become, small populations and then grow. We know that the UK B117 has seemed to increase in the population as well. These other new variants can as well. So I think we just have to stay tuned and just understand, just as Dr. Steit said, anytime you have active viral replication going on, and when that virus is replicating inside your body, that's when those mutations or those substitutions can occur.
And I think that's always going to be the challenge for vaccination. Why it's so important that we continue to wear our masks, we continue to do the measures of social distancing, because we know that those things clearly work. We also know that the vaccine appears to really work well in addition. And I think that will take time, but we'll be studying those variants to determine just how active the vaccine is. By and large, what I'm reading is they expect it to still be. The only one that's been a bit of a concern is the South African variant. And as I recall, the J&J vaccine and some others still showed some activity against that.
Some pretty good activity and efficacy against severe disease, hospitalization, and death. And I believe these new variants that they've identified in the United States, they have significantly different mutation than what has been discovered from the other variants around the world as well. So totally different. We just got to wait and see as we get more information how that will affect us moving forward.
But the rules of infection control,
they don't change.
They don't change. They travel with you wherever you go, do not change. All right, other questions?
Just one more, shifting to a more positive question, we could say.
Well done.
There you go. When we see these numbers going down, I know that since Friday, I think the average number of new cases has dropped below 100,000, or it's right around 100,000, which you look at over the course of 2 months. I mean, it's come down a lot, still very high. Just from a personal standpoint, are these encouraging numbers? What's the talk in the hospital now about the trend that these numbers seem to be following?
Well, I think, Cody, it depends if you're talking to Dr. Wild or to me, because sometimes we call him Darth Wild. The U.S. national testing numbers are down from 2 million to 1.6 million, and that means there's fewer people being tested now. Are they getting tested because it's too cold to go outside and get tested? Or is it because there's fewer people who want to be tested, fewer people need to be tested, or less emphasis because now the emphasis is shifted over to vaccine? Not sure of that, but they're down about 20%. However, the number of new cases is down by a much greater number, from 230,000 a day to about 85,000. So the drop in the number of new cases is much greater than the drop in the number of tests. So I don't think it's just a testing variable. The second thing is that the number that is much I think, better to follow, though it lags behind new cases by about 2 weeks, is the number of hospitalizations, right? Because what we know is if you get sick, you get hospitalized, that's just an absolute number. That's not subject to whether or not you got tested or not, or all the other variables that can affect it. Rather, that number about how many people are in the hospital is really important, and that number is clearly dropping. You know, we hit a high of around, gosh, almost 200 patients altogether, and about 110 or so acute cases. And today we're down to 32. We've dropped 65%. That is a real number. Now, why is that true? I think a couple things. You know, nursing homes are being vaccinated. I think that's having an effect. And there's differing opinions about whether or not vaccination has had an effect on the number of new positives. I don't think there should be much question about that vaccinations having an effect on the number of hospitalizations. The second thing is that about a third of the U.S. has already had coronavirus. So if you take that, there's just fewer people to have coronavirus and to be positive and want to go get tested. Plus, the number of people who have had coronavirus, it is speculated, though not proven, that they may be people who have less masking behavior, and so they were more likely to get it, and they're the ones who've already gotten it, and so they're going to be less likely, and that may cause a drop in the number. And I think, frankly, masking works. There's really no question about that, and the cold has driven people indoors. They're less likely to be outside. Now, we've said before, being outside is a good thing, but it doesn't mean you can be outside up close, personal, and no mask. And unfortunately, I think sometimes outside translated into I'm free and I can do whatever I want. That's really not the case. You still had to follow the rules of infection control. But overall, I think there's behavioral issues. I think there's epidemiological issues around masking, et cetera, as well as the number of people who've already had coronavirus. And I think there is some vaccine-related issues. And all those things are combining. It's been speculated there may be some seasonality issues, but it's too early to know about the seasonality of this coronavirus, I think. Anything you'd add?
No, you know, I agree. And I think the one thing to remember, too, about the testing issue, even if there isn't testing going on, if you have large amounts of spread of the disease in the community, you have to understand what percentage of that will go to the hospital. So we aren't seeing that just, large numbers of people still going to the hospital as we were before. So I think that helps with the testing as far as saying, well, it's not just the testing, because even if the virus is out there and spreading, you're still going to have large amounts of infection. And those, you know, we know a certain percentage of the people, 15% or 10%, will be going to the hospital anyways.
All right, other questions?
Hi, guys. It's Taylor, Channel 41. How are you this morning?
Hi, Taylor. Good.
I'm sorry if I missed this last week. I haven't been on the call in a little while, but if I missed this topic last week, I apologize. But have you guys touched at all on any effect that the severe cold has on a person's susceptibility of catching any virus, COVID-19 included? But we've talked about how it could make you cough more because your lungs are dry, that kind of thing. Does the severe cold like this increase a person's susceptibility at all?
That's a great question. I don't think it was asked last week. Taylor, I thought you were going to ask if the Chiefs won or lost the Super Bowl, and I was going to have to tell you, you have to have a life, man. But no, it's about a really relevant infectious disease.
It's bad if I don't know that one. It's bad if I don't know that one.
What do you think, Hawkeye?
Well,
cold weather?
you know, we touched on that a little bit about if people, asthmatics in particular, if they're going out exercising. I don't know a lot of data behind just the cold weather itself causing you to be more susceptible, especially down in the lungs and the bronchioles and what have you. You and Dr. Castro did discuss about it is probably more dry, and doing some prophylactic albuterol inhaler, if, again, for asthmatics, if you are using albuterol inhaler anyway. But I'm not aware really of any data suggesting that you're certainly more susceptible just because of the cold weather to a viral infection.
Right, and we see the numbers high even in warm weather climates.
Yeah.
And so as a result, I would say I don't think that's a case. The other thing you have to remember is our bodies are built in a fascinating way. We moisturize the air so fast that comes into our body because of our oral cavity that by the time it gets into the lower reaches of the lung where infection would occur, it's pretty moist, even though the air may have started out as being pretty dry. And so, and especially that's true when you breathe in through your nose. But the truth is, at the end of the day, people who live in humid climates and people who live in very dry climates are getting the virus at about the same rate. So I think it's just the seasonality of the virus, and more than that, it's about our behavior. Other questions? All right. Jamie Wagner, welcome back. How the heck are you?
Thank you. Good.
All right. So both the Pfizer and Moderna vaccine have shown to have been cause a robust immune response. You and I were talking about how we both got that robust immune
Yes, we
response.
did.
I guess that's good, which can result in enlarged lymph nodes in a small percentage of breast cancer patients. Talk to us a little bit about that, about what side they should get the vaccine on, things like that.
So we know that more of the data has been through the Moderna vaccination, but about 10% of patients will have lymphadenopathy, which is just meaning swelling of the lymph nodes in that armpit of the side that the injection is given. And after the second, they saw as much as 16%. So with that, we have to pay attention because we also know that we can get enlarged lymph nodes with breast cancer diagnosis. So Dr. Winblad and I have worked a great deal on how are we going to work with these patients from a screening standpoint, but also from a breast cancer standpoint, because the bottom line is, despite the fact that we're having this, we do not want women to continue to delay getting their mammograms, because if we think back from this last year, we've had a 50% decrease in diagnosis, and women are getting diagnosed at more advanced stages. So I don't want this to be an excuse for women to not get their mammograms.
Well, let's just say that 50% decrease that's a big number, and I don't think coronavirus is curing breast cancer.
You're right, it's not.
So that's spooky, because that just means that's going to be showing up in a bad way later on.
And we've already seen that. That is our big concern, is that we know with this lymph node enlargement, it can be somewhat challenging from a clinical standpoint, but if you are getting your mammograms at the right place, we can overcome that.
Yeah, that's tough. So Dr. Winblad, you read a lot of mammograms. Are you seeing this among our patients?
Yeah, I mean, so axillary lymph nodes are visualized on most of our breast imaging exams, such as mammograms and MRI. You just saw a great picture of a mammogram showing some enlarged lymph nodes. We have observed a small percentage of our patients presenting with enlarged lymph nodes following the vaccine. Once again, this is a small percentage of patients. This is a benign finding, nothing to be alarmed about. This will resolve. The important thing to note is the vaccine does not cause abnormalities in the breast. So if we ask the right questions to our patients, we can usually determine that this is from the vaccine and not from breast cancer. So in breast imaging, we're asking our patients a few extra questions on their intake form. We're asking if they've had either dose of the vaccine, and also the laterality of the administration. We're asking which arm they had the vaccine on. It's also important to note that having the COVID vaccine does not limit our ability to find breast cancer on imaging. If we do see this, we may have to call a patient back and do some extra ultrasound imaging, a few months after their vaccine, just to make sure that the lymphadenopathy resolved. But it doesn't limit our ability to find breast cancer. We don't want women to delay breast cancer screening too long. Dr. Wagner is absolutely correct. We saw a large decrease in cancer screening exams during the pandemic, and we don't want patients to have delayed cancer diagnosis. So if you're due for your screening, or you've been delaying your cancer screening during the pandemic, come now, get screened before you have the vaccine. If you happen to be due for screening at the same time that you have the opportunity to get the vaccine, it's acceptable to wait a month or so to get your screening mammogram, but please don't wait too long. We don't want to have delayed cancer diagnosis.
How long does it take for this adenopathy to calm down, guys?
We're kind of seeing, just historically, from historical data, it typically would be around 4 to 6 weeks, maybe up to 8 weeks. Somewhere in that time frame, we expect to see a decrease in size of the lymph nodes. And from an imaging perspective, we can also often tell if lymph nodes are reactive simply to a vaccine as compared to due to breast cancer. And if the breast is normal and the lymph nodes have a very specific appearance on ultrasound, we're pretty good in breast imaging about being able to identify these as due to the vaccine and not breast cancer.
Yeah. So when patients call, they're a little spooked about this. What do you tell them?
Well, we are really encouraging them to not delay overall getting their screening mammogram. If they have a strong concern, because having a call back to have any more imaging after your first screening mammogram creates a lot of anxiety for women, some more so than others. So if you just have to be honest with the person that you are, and if it is going to cause a lot of anxiety of this potential, then we just say, let's wait about 4 to 6 weeks, but let's go ahead and schedule your mammogram. Let's get it rescheduled. Don't delay about 4 to 6 weeks, maybe as long as 8 weeks, but we would not endorse anything longer than that.
So what do you two, from your perspective, what are we doing to help make sure breast cancer screening is safe and try and reassure folks that it is okay to come in and be tested?
From the time of July, when we reopened screening mammography, we went to great lengths to make sure that our environment is safe. We have spread out the schedule so that patients aren't quite so condensed as far as the scheduling to get in for the mammography. We have done extraordinary revamping of how we allow patients to come in and sit in the waiting rooms, really extensive cleaning of the machinery between every patient. So getting your screening mammogram really could not be a safer environment, because we, very early, when we were still shut down with mammograms, when everything was shut down, we were seeing patients come in at more advanced stages. And that was such a strong concern that as soon as we had the opportunity to reopen, we wanted to make sure we had it together, we had it right. We prepared for that open date many weeks in advance. So it is an incredibly safe place for patients to be.
That's really important. So, Jill, let's see if there's questions out there from our community. And if not, I've got some more for Drs. Winblad and Jamie Wagner, too.
We do. We have some questions. Marcia wants to know, if you have breast cancer in one breast, should you get the vaccine in the arm on the other side, or can I get it in my hip?
So we are absolutely recommending that if you have a known diagnosis of breast cancer that follows the vaccination follows the diagnosis, we want you to get it in the opposite arm, because that is part of what we can see is enlarged lymph nodes as a result of breast cancer diagnosis. And so it can be something that we have to work through. We have a very strong multidisciplinary team, and that is what is critical in those moments. Our radiologists are as much part of the treatment team as the surgeon or the medical oncologist. Mm-hmm. So we can come together and clinically figure it out, but it's always just better to have it in the other arm. You could choose to have it in your hip, but I think the majority are just getting it in their opposite arm.
Hip injection is a vaccine, what do you think?
Yeah, I don't know. I'd have to go back and look at the specific wording on the EUA. The guidance, for the most part, is the deltoid, is the shoulder muscle. So
it should work either way.
You would think, yeah. I mean, you just need to get it into that muscular area. Again, that's where the vaccine, a little bit's going to be taken up, and the rest is going to drain to those lymph nodes in the interstitium, in between those muscle fibers. It's going to drain to those local lymph nodes, and that's what we're seeing. So I'd have to look at the specific wording, but the general guidance is that shoulder.
And just as our recommendation has just been, it is completely safe to get it on the other side. It doesn't mask anything with your cancer diagnosis or have any long-term sequelae from your breast cancer diagnosis or the treatment. So the other arm is completely fine.
Okay.
Yeah, and Mary says, I was very pleased and impressed with the measures KU took to increase safety during my mammogram.
Oh, good.
And she said, so the question is, do get it on my non-operative side, ?
Absolutely. In general, because we are also not just talking about this enlarged lymph nodes from the screening standpoint, but we are paying a great deal of attention for patients who currently have breast cancer, but also those who have undergone breast cancer treatment, because part of breast cancer treatment is having lymph nodes removed on the cancer side from your armpit. So we have been very aware of this, and we've always encouraged patients to get any injection, for that matter, in the non-cancer side because of side effects of lymphedema, and this would be no different.
And I think it's such an important part of the immune system process is developing those enlarged lymph nodes for the reaction to this vaccine as well. So.
Jenny says, what if I had a double mastectomy?
So if you had a double mastectomy, part of it is information I don't have, but if only one side was cancer and the other one was from a risk reduction or a prophylactic standpoint, most likely there were not lymph nodes removed on that side, and therefore it would still be completely safe to get it in that other arm.
Cindy wants to know, my mom-in-law had lymphedema after breast cancer. So will my arm swell if my lymph nodes are swollen from the vaccine?
Will our arms swell
from
The
lymphedema? I don't think.
Like her mother-in-law.
Oh,
will it make your arm swell?
No. So we have not seen arm swelling as a result of the response from the vaccine. That process, and this is just a very short transient process of this lymph node swelling specific to the vaccine, which is a very different process than how we end up having lymphedema which is a chronic progressive potential problem as a result of lymph node removal. Just a little bit of a different physiologic process, and so you wouldn't expect that.
Dr. Weinblatt, when you look at the mammogram or ultrasound, can you tell a difference between a lymph node that has cancer or a lymph node that's been a result of vaccination?
So not always, but there are features in lymph nodes, especially that we can see on ultrasound, that are a little bit more characteristic for reactive lymphadenopathy or enlarged lymph nodes related to an infection or a vaccine or something of that nature. So typically for us, when a patient's breast is normal and we see this certain appearance that looks like reactive lymph nodes where they still look very regular and just a little thickened, that's fairly characteristic. And at the most, we might need to do a follow-up ultrasound just to ensure that these lymph nodes have gone back to the normal size. But typically we're able to tell, especially when we get the appropriate history from the patient, the timeline of their vaccine and which arm they had the vaccine administered on. This really helps us make appropriate diagnosis.
Yeah, that sounds, I mean, I'm sure that somebody who gets that phone call would be so scared about, oh my God, I have these, and then just kind of sitting around having to wait for 4 to 6 weeks to figure out if it's vaccine or not. That's got to be really hard for folks.
It is. The one, I guess, aside I would put with that is it's very different if we're only seeing an enlarged lymph node on a mammogram versus if there is something actually in the breast that is being seen at the same time. The pathways for our differential diagnosis, trying to figure out if it's breast cancer, is very low if it is isolated to just being lymph node enlargement. And we're also coupling that, as Dr. Weinblatt said, with a very thorough intake process. So if it's on one side and we know you've had the vaccine, your concern really can be very, very low that it will be something on that follow-up.
So that makes a lot better sense, or not, at least more reassuring. And then the other thing, isn't the clinical trajectory with the folks I've seen in my clinic who have had it and get the adenopathy, it comes on pretty fast?
Yes, they saw in the few patients that they did see it in the Pfizer and then more prominent in the Moderna, it was about 1 to 2 days following the injection that they were seeing the swelling. Some were up to 10 days afterwards, but that's not the more common. It's more that short term.
Yeah. You know, I don't know if you saw in JAMA, at the end of last week, I think it was, looking at the millions of doses of both Pfizer and Moderna and going back to look at allergic reactions and other sort of reactions. Mm-hmm. The incidence is incredibly low, whether it's Moderna or Pfizer. Any comments or thoughts about that?
Yeah, absolutely. I mean, we have seen this. That with the VAERS, the Vaccine Adverse Events Reporting System, but also now the VSafe for these COVID-19 vaccines. Both of those reporting systems, have shown that these reactions are not anything more above what you have or would expect for other vaccination or just present in the general public for one reason or another. So I think, this continues to lend credence that these are safe vaccines.
Yeah, and the allergic reactions are like 4 per million doses given in one and 2.5 in the other. So essentially the same, I think, and it's incredibly low and no reason to not get the vaccine when it saves so many lives.
Simone has a little bit of a math question. She said if I wait...
Math. Here we go, baby. It's Monday morning.
If I wait 6 to 8 weeks after my mammogram and the shot takes 6 weeks after the second dose, that could delay a mammogram by 12 weeks. What impact would that have on a cancer diagnosis?
That's a great question. I'll turn to Dr. Wagner and Dr. Weinblatt about that.
So I just want to also make sure I'm completely understanding the
question.
So
if you get your first
shot. So the mammogram was already delayed? Is that the question?
No, if I get my shot, I haven't had my annual mammogram, I get my shot, I have to wait 6 or 8 weeks after the shot.
Well, you wait 4 weeks for your first shot, then another 6 to 8 weeks, that could be 10 to 12 weeks, so you hadn't get a mammogram yet.
Right.
Dr. Weinblatt.
I can see Dr. Weinblatt really wanting to comment on this. We've talked about it a lot.
First of all, I want to let women know you don't have to delay your screening mammograms, and I don't want that message being sent across to women who really want to come get your screening. Having your COVID vaccine and potentially having some enlarged lymph nodes, first of all, that's a small percentage of women. Second of all, it will not limit my ability to find breast cancer, so you don't have to delay. You can come in. There's a very small percentage of the time that I may have to call you back for an ultrasound to look at those lymph nodes, but it's a small percentage of the time, and if that doesn't bother you, please come in and get your screening mammogram. Ideally, if you're due now or you've been delaying, please come get it now before you get the vaccine. I think for most women, the likelihood that their due date and the opportunity for a vaccine fall at the same time is pretty low. If that does happen, don't feel like you have to delay your screening. Some women may want to delay for a month or two. And if you're entirely asymptomatic and low risk, that may not be a huge deal. But I don't want women to delay too long for the reasons that, you're alluding to, is that it can lead to some delayed diagnosis. And we know that for breast cancer patients, the earlier the diagnosis, the better the outcome. And so, we kind of have to look at all the factors when we decide when to come in. But it's very safe.
Yes, and a little bit of what Dr. Winblad is also talking about is we unfortunately can't predict what a significant delay might be, because we have a lot of different types of breast cancer and they behave differently, they progress differently. So waiting 12 weeks for a very, as we sometimes call it, lesser aggressive, faster moving type of breast cancer, it might be okay. But if you have a very aggressive type of breast cancer, 12 weeks would not be okay. We could see a significant difference in your outcome. But unfortunately, when it's still inside the breast and we don't have a diagnosis, we don't know. And we don't know what type you're going to have. So please just get the screening mammogram done.
Well, and given, really, we don't expect it. I'm going to follow on a point Dr. Winblad made, which is we don't expect a lot of vaccine until late March, early April. We think things will open up with the J&J vaccine and as Moderna and Pfizer ramp up. So, go get your screening mammogram right now.
Yeah,
Because this is the time to do it, because you're probably not going to be in line to get a vaccine right away just because there's not a lot of vaccine available. So I think that point is really salient. So do we have openings to get people screened? Can we get it done?
We absolutely have openings. And scheduling could not be easier. We have online scheduling. It literally takes about 2 minutes to do that. Not only during normal business hours, we have nights and weekends times. We could not have made this more convenient and safer for women to get screening mammograms.
All right, and Dr. Winblad, I think you're going to probably echo the same thing. It's easy to get done, and we have different locations where we can do it.
Absolutely. We have 3 locations, evening and weekend opportunities for screening, and schedule online.
And obviously I'm sounding a little pro-KU, but the truth is, whether you get it here or you get it anywhere, just go get it done, because we're all, you're going to get a good read, you're going to get the mammogram done. Be safe, don't be sorry, get your mammogram, then go get your vaccine, especially come April.
Okay, Adrienne wants to know, how long does this lymph node swelling last that's caused by the vaccine? Is it just 8 weeks?
It has seen on an average of about, 12 to 14 days is when a lot of it is starting to resolve. It has been as long as 4 to 6 weeks in some. It's unfortunately, we're still early in this process, and that's variable. And there's not been a lot of data because, to be very honest with you, when the original studies that were being done on the Moderna, even showing lymphadenopathy, that women weren't following with mammograms. And so what that true resolution, feeling it versus what we can see on a mammogram, we don't know that.
All right. So,
and Hawkeye, from your standpoint, as far as the adenopathy goes, just in general, whether you have it up here in your neck or down in your arm or wherever the lymph node is draining, you think that's about right? About 2 to 4 weeks afterwards, you ought to have
it should resolve quickly, like you said. Majority are 12 to 14 days probably afterward. So it shouldn't be going on that long. Certainly nothing that you can appreciate, even if you were trying to do an exam on yourself, looking for lymphadenopathy, you probably wouldn't be able to appreciate much.
Melinda, we have some just regular COVID questions today. Melinda wants to know, what do you think about rapid at-home testing for COVID-19?
All right, coming, we hope, and with some degree of certainty, maybe this summer, I hear.
Yeah, I think they have 1 or 2 that have emergency use authorization.
Yep.
If you can get it, I don't think there's any guidance really on how often you do it. Do you do it once a day? Do you do it once every other day? Are you just doing it for symptomatic issues? Are you having a cough or fever or something of that nature? Hopefully it will be rolled out. It will be more accessible. And if people are doing it and they're positive, they stay home. But we have to understand these tests are probably still not going to be the gold standard PCR test. So there is the chance for false negatives and false positives. But right now they're not rolled out to the general population. But it's something, it is one more piece that we can use to help prevent the spread of disease, especially if you know at home that it's a positive test. More than likely it's a true positive, but there's always that chance it's a false positive as well. then hopefully you will stay inside, or at least stay inside and isolated until you can get a confirmatory PCR test. Staying out of the public to help to reduce the spread of the disease overall.
And just to say, it's not inexpensive so far, and I don't know how readily accessible it is. I honestly haven't gone down to CVS to find out, or Walgreens to see, but I think that they are coming. I read that they'd be more and better supplied this summer.
Yeah.
I think it could become, as long as it's priced reasonably, a good step in our armamentarium and how we battle COVID to try and get it under control, drop the R naught down to a point where transmission is a much less common event, and that's when we can really feel safe about how we can get back towards a normal.
Ruthie wants to know, how rare is reinfection of COVID-19?
Yeah, it's really rare, Hawk. It does happen. We just read about one today. Or over the weekend, there was a gentleman who had, I think it was in France, who got a second infection, this time with the B134, 135 South African one, and became much more sick with that one and is critically ill. But that's the exception, I think.
Yeah, right now, I think the CDC still says it's rare. Infrequent. We know that there have been at least 3 documented cases in Israel, I believe, of people who've been vaccinated and now have gotten infected with B1351 out of South Africa as well. So things are changing. The viral dynamics are changing. The new variants are adding a new wrinkle to this. Still continue to wait for the data, but we know it can happen, and that's why it's all the more important to continue to do masking, distancing, not meeting in large gatherings, not mixing your bubble.
Do you foresee a time when the vaccine has been changed or altered? I know Moderna and Pfizer can change it around pretty fast, and that we're all going to be saying in 6 months or so we're going to get a booster, so we have protection against the South African variant. Do you think that's coming?
I do. I'm sure they are working. I'm sure they've developed a spike protein sequence right now that is consistent with the variants that we know of. So I'm sure they have a lot of research going towards that and have people working on that, monitoring variants around the world.
Yeah, I'm going to bet that once they do, they can show it's effective. They're not going to have to do a big research study on safety. I think they're going to probably just say, nope, we're going to start using it just like they change the flu vaccine every year.
Stephanie wants to know, can you have a stroke from the COVID vaccine?
Well, we know you can have stroke from
Live.
COVID infection.
Yes.
I haven't seen any reports of that. Of CVA, cardiovascular accident, stroke. I haven't seen any reports of that from the vaccine itself. But we know from COVID-19, because of the direct viral damage, but also the collateral damage that your immune system can do, you can have changes in your blood vessels that allow you to have blood clots, and that's what happens in these types of stroke, is blood clots in the brain. So we certainly know that can happen with true infection, but I haven't seen any reports from vaccination.
I've not seen that either. And when they do submit their EUA, all the data's out there. You can go and examine it and take a look at it. It's free public information. And what I can say is there have been 440,000, whatever the number high, deaths from COVID-19 here in the United States, and 0 deaths from vaccination in the United States. And so I don't think we have to be concerned about that. I think that there will always be people who have a vaccine, whether it's COVID, influenza, anything, and then later have medical problems. The vaccine doesn't prevent medical problems from occurring. And so the natural incidence of how often there will be a stroke or a heart attack or cancer or breast cancer in the U.S. population will continue to occur. As we said a moment ago, unfortunately, neither the vaccine nor coronavirus are preventative of those. In fact, we know the coronavirus causes stickiness inside your body, and as a result, you're much more likely to have strokes and heart attacks, kidney disease, liver disease, and problems as a result of COVID than you are from the vaccine. And again, it's not close.
Shannon has a question. She got her first dose of the vaccine on February 5th. She said the side effects hit hard on the first one because it turns out I already had COVID-19. Symptoms of the infection showed up 2 days after the vaccine. I'm due for the second vaccine on March 5th. There are talks of a person only needing 1 vaccine and previously infected. They also say not to vaccinate until after 90 days after the infection. I'm not sure how to proceed. What should I do?
Hawkeye, I'm glad you're here.
Yeah, I think there's some misunderstanding there. Get your vaccine as you are slated to do. There are trials going on with one vaccine dose, but that is not Moderna and Pfizer. Their trials, their information is from 2 vaccine doses. So if you got Moderna or Pfizer, go back and get your second dose. You don't have to wait 90 days. Certainly, if you are someone who has received the monoclonal antibody therapy, we do recommend 90 days from receiving that. Initially, especially when we were having our healthcare workers vaccinated, we did advocate for pushing it out 90 days so that we could get those people who've never had infection or would have immunity vaccinated, but that is no longer the guidance. There is no minimum time between infection and vaccination. So if you've had the infection, go ahead and get the vaccination as soon as you are able to. Most of that is going to center on if you have completed your 10 days of isolation at home so that you're not out in the public with the actual infection. But go ahead and get your vaccines. From this case that she describes, I would say go ahead and get your vaccination as soon as you are scheduled to.
All right, John wants to know, I have a friend that has seizures, and she wanted to know, is it safe to get the vaccine?
I think it's safe to get the vaccine, maybe in some ways even more so.
Yeah, the simple answer is yes, and I would agree with you. We do know that COVID-19 can cause central nervous system or CNS effects as well. It can cause confusion or encephalopathy. I'm not sure it can exactly cause seizures, but certainly you are going to be at risk for that. And you don't want to increase your risk of having breakthrough seizures, especially if you're on medication. You can go ahead and get the vaccine. It'll be safe for you.
All right. Hey, tomorrow, KDHE Secretary Lee Norman is back to talk with us about the vaccine rollout across Kansas. You're not going to want to miss that. We like to tease and make fun of Lee, but he is a great guy, and we have a really good time visiting with him. He always brings good information.
We're all wondering what hat he'll have.
Yeah, which hat he'll have. That's well, he had his great and cold north hat on last time. We'll see what he brings up this time. Well, he'll talk to us about how the vaccines are progressing through the state and what the role of the county health departments are going to be in helping us manage that vaccine. That'll be a great program. Before we sign off today, though, final thoughts. First, Dr. Windblatt.
No, thank you for having me. I really appreciate being able to talk to everyone about the side effect we're seeing with lymphadenopathy, hopefully decrease the fears women have about getting their screening mammograms. So please come see us.
Well, and the numbers are down, so get your screening mammogram now. Thank you very much. Dr. Wagner.
Like Dr. Windblatt, I just want to echo, it is still critically important to stay on top of getting your routine screening mammography and not pushing it out despite this, I would say maybe just a little hiccup of new knowledge. We have the experts that can still take care of this and take care of your breast cancer.
Yeah, so true. I just want to thank you both for taking time out of your incredibly busy day for being here. It's a delight to have you both here and have you back. And I think the message I'm hearing today is go get your screening mammogram because you don't want to wait. I mean, that 50% drop in the diagnosis of breast cancer, it did not go away. I just think that just sounds dangerous to me. So thank you guys both for being here. Come back anytime. We're delighted to have you back. Hey, many of you continue to have questions about the CDC messaging around masks and maximizing the fit for cloth and surgical masks. In just a moment, Dr. Hawkeye, who is going to show us the video that he was kind enough to record, which is a how-to video on this subject of how to put on your mask given the new recommendations from the CDC. Now, listen. We've been talking a lot today about vaccination and things like that. That's really important. But the rules of infection control have not changed, and they're the ones going to keep you safe. They've kept you safe up until this moment. They keep you safe today. They'll keep you safe going forward. Let's review. What are they? And now this is a multiple choice test. Rule A, wear a mask. Rule B, stay 6 feet away and socially distance. Rule C, cough at your elbow. Rule D, don't go out if you're sick. And Rule E, all of the above. If you did not answer all of the above, it means you need to watch this program far more. And right now, you'll learn more about Rule A, how to make sure that mask fits perfectly. We're back with you tomorrow. Remember, there's still no place like home. Let's hear from Dr. Hawkeye.
So the CDC guidance is not to double mask. Their new guidance is that improved fit will help reduce the risk of catching coronavirus and help reduce the spread. Currently on the CDC website, they do have that it is important to make sure that you improve the fit of your mask as much as possible. And you can do that by tying the mask or improving the fit of the surgical mask. So first I want to make sure that I have my hand sanitized with alcohol gel. And the easiest way to do it is to just pick it up before you place it on your face. At that point in time, you just fold it in half. So it's kind of folded like a hot dog bun. Next, you work towards tying the loops. And the easiest way to do this is to do it by 2 finger breaths, tying the loop around. And you really want to try to get it as close to the mask as possible. But as you can see, we've just tied a simple little knot. Now to the other side. The next step is to kind of get it to form to your face initially. And that is by using the nose and the metal band, and then also pulling it down around your chin. So obviously you can see here there is still some gaps. The last part is trying to fold in those open gaps, fold it in around your face, so that you can reduce the amount of open space around the mask and the face as much as possible. And once you do that, you should have as little amount of gap as possible. Again, this is all to improve the fit, to improve any open air exchange if you are expressing the disease or the droplets out into the community, or if you are inhaling as well, this will help.